And now we straight away move on to the next topic by Professor Nazrul Islam, who is a renowned glaucoma specialist from Bangladesh, and he is currently working at Bangladesh Eye Hospital, and he is the former head of ophthalmology department and head of glaucoma division of Burdem Hospital, Dhaka. And he is a proficient phacosurgeon as well as a glaucoma specialist, renowned. And without wasting time, I'll just ask him to deal with how to tackle the residual glaucoma after primary surgery. Professor Nazrul Islam.
I'm really honored to have participating in this very prestigious webinar, and thanks to APGS and also AIOS. My topics will be the treatment of residual glaucoma after a primary glaucoma surgery. I do not have any financial disclosure. As all of you know, that a common surgical treatment currently is the filtration surgery with its modifications, tubes, and mix. But in our country, in a short survey, we found in Bangladesh that still more than 90% is the filtration surgery, and tube is 7%, less than 2% is the mix. Mix, though it's very popular now in the developed country, but in our country, does it really applicable? Because you can see in this table that many of the mix, different kind of mix, have the IOP lowering capacity 2 to 8 or 9 like that. But we get the patient for surgery that comes in the very advanced stage or in the end stage. So we need to do something which lowers more intraocular pressure. If we look to the PTBT, that is primary tube versus trabecular study, we find that after 3 years of follow-up, that still 33% fails in the tube group and 28% fail in the trabeculectomy group. So whatever surgery you do, it fails, and there is some residual glaucoma. That is some remaining glaucoma we find, and we have to manage. So what is the residual glaucoma? You know that glaucoma that remains is IOP, or this not is failed glaucoma we have to treat is the residual glaucoma. And all of us, we know that why the surgery fails. Because it's a natural phenomenon that our fistula that we make, especially in the trabeculectomy, filtration surgery, it is supposed to fail. So we try to give anti-scarring agents, my MMC, 5-FU, and other things. How to understand that my surgery is going to fail and have some residual glaucoma? Number one is pressure going up, then flat bleb, vascularization of the bleb, highly elevated cystic bleb or tenon capsule. So this way we can understand that our surgery is having some residual glaucoma. The first suggestion is you revise your patient with the gonioscopy. See the internal block is not or not, like with the iris, ciliary body, vitreous, blood clot, fibrin, anything can block. So if it's not, then of course you have your different methods and procedures in your armamentarium with your choice and availability. So this is totally my experience, how I manage the residual glaucoma in my practice. So you can see it's 11 options that is possible. You can use 1 option, 2 options, or 3 options as you like. You can see here the digital massage. I believe it is very important because after a few days of surgery, you can find the pressure is getting higher. Simply, if you can massage the bleb, you can see the fluid comes from the chamber and ultimately the fistula becomes open. But I always request that you should do it yourself by the doctor himself or herself, because the patient sometimes is taught, but they sometimes makes really a mess and should not be advised, in my opinion. Coming to the argon laser suture lysis, even few years before I used to use the releasable suture, but if you have the facility of argon laser, you can cut the suture, 2 or 3 suture, or also you have given the nylon suture, you can cut it and you can massage, you can have the digital massage, definitely the pressure is going to down. So this is way you can manage your residual glaucoma. Definitely, if the facility is not available, you can still use the releasable suture and you can release it whenever it's needed. If you use MMC, MMC or antifibrotic agent, then it should be released at least after 1 week or 2 weeks. And if it's not, then you can release it anytime. So this is the very good way that you can titrate your intraocular pressure by putting the suture. Now the bleb needling, I like it very much, though there is a lot of literature says that bleb needling doesn't work, but I do frequently in my patient. And if you look here from 1996, David Greenfield first introduced that bleb needle really works in the NIE, Newark Eye Infirmary found, and for significantly long-lasting pressure reduction procedure is the bleb needling. And recently in 2016, Dr. Wilson Michael showed if you use the AC maintainer, continuous fluid in the anterior chamber, blade needling has 60% success rate for longer time. Many people, Egyptian group, they suppose that you can use MMC, though I am not really using the MMC in this blade needling. Rather, you can use F5FU, but for last 2 years, I am using the anti-VEGF Avastin, that is bevacizumab. And I use the blade needling with bevacizumab, that I find very good result. We had to do the subtenon first, separation of the subtenon fibrosis. Then I go even under the superficial scleral flap. So you can put some air in the anterior chamber if possible. And this way, and if you really use a AC maintainer, usually there is hyphema usually washed out and possibility of hyphema is less. So this way you can have better result in the residual glaucoma. Definitely, medical treatment is one of the good choice. If everything fails, you can again start the medical treatment. And I'm not going detail for that. Revision of bleb is again very good idea. If you have the patient convinced and if you think does not done very old, you can think of revision of bleb. I have used here the subtenon low concentration MMC. And now just opening my previous flap. Just open a previous flap. And just open it, see my fistula is closed or not. If it is not closed, if it is small, make it big. If iridotomy is small, make it broad-based iridotomy. So this way, the revision of trap in many authors showed that it really works, and at least it goes another few years with the good IOP diminishing. Now, Dr. Shulanjang has nicely showed some mixed procedure, and I'm also showing that if you have some practice of some kind of mix in your practice, we can use in the residual glaucoma too. This is the ab externo and the 360-degree trabeculotomy. Dr. Shulan has shown with the catheter, the illuminated catheter, very expensive, but in our country, we don't have much expensive catheter. We cannot use it. So we use the 5O proline. With the low-term cautery, we make the end a mushroom shape. And so easily, if it goes to the trabecular meshwork, and if it goes very easily, you are sure that it is not obstructed somewhere. If it is obstructed, definitely you cannot do it. You should bring it out. So whenever it goes easily, you will easily find on the other end, if the end comes out, then you can take it and cut all the 360-degree trabecular meshwork. The only problem in this procedure is the hyphema. And in the perioperative, you will find a lot of hyphema sometimes less. But postoperative also, you will find hyphema. But I have seen most of the cases, the pressure comes down. But many authors have suggested you have to put the cohesive viscoelastic just after surgery so that the hyphema become less. And you can definitely wash after surgery. Another mix is the Kahug dual blade. And I had the opportunity to use few blades. Now it is not available in our country. And definitely if the eye is open angle glaucoma, if you can see the trabecular meshwork very nicely, yes, you can try in the residual glaucoma cases too. And I have seen the patient is not coming down even with many drugs, the patient's pressure comes down. And one thing you can do, you can see the trabecular meshwork clearly here, then you can put some viscoelastic also, the cohesive viscoelastic also. So there is some dilatation. And of course, after, if there's some hyphema, you can remove it and wash it. Recently, I have done few cases of BANG. It is the bent angle needle goniectomy. Dr. Ashami in USA first showed it, and I'm becoming really encouraged to do it. And you see, it is almost like Kahug dual blade. And you can simply excise the trabecular meshwork here again, like the Kahug dual blade. from one side, then to the other side, and at least 100 to 120-degree trabecular meshwork, you can excise this needle, bent needle. And after that, the same thing, that might be some hyphema, and repeatedly you have to wash it operatively. And even after surgery, if there is no hyphema, so you have to make the eyeball a little bit tight, giving some scope and air and make it tight. Yes, the repeat trabeculectomy, yes, definitely a choice. This is one of my patient. Patient had two trabeculectomy. You can see here two trabeculectomy, nasal and temporal, in by two of my colleagues. And patient came to me. I advised for the tube implant, but unfortunately, patient could not afford the tube. So I thought, okay, patient is come down, so let me do the trabeculectomy. I did the third. And what is the difference between the primary and third? Difference is that you have to use the higher concentration MMC sponges, keep for longer time, make larger flap, make the larger block incision. So I think this way, definitely this fistula is not going to close. This is one of my surgeries about 9-10 years before, and the patient is still come to me with a good result. So repeat trabeculectomy, yes, it is also a possibility for the treatment of the residual glaucoma. Dr. Bhaisini also showed the glaucoma drainage devices. Dr. Shulan also showed. Yes, this is one of the very good alternative in the management of residual glaucoma. And if you look to the TBT study, they have done the either tube or trab after primary surgery. So what they have found? They have found after even the second trab, they found 9% in the tube group, they need additional surgery. And 29% trab group, they need additional surgery. So from this study, we can say that tube is better in the residual glaucoma cases after the trabeculectomy. So definitely you can use the valved or the non-valved devices. Though in another study, the ABC study, Ahmed-Barveld comparison study, found that the result of decreased intraocular pressure is best or more by the Barveld, the non-valve tubes. Though Ahmed valve had minimum complications. So actually, it is the surgeon's preference and choice which valve he or she wants to use. Otherwise, more or less, the outcome is same. But in my practice, I use mostly the Ahmed valve because in the RD, which is really very fortunate, it comes from India, from Orolab, and it is really cheaper. I think 10 times cheaper than the Ahmed valve. So we use for my patient who cannot afford much, so for them. Otherwise, I prefer Ahmed valve because most of the patients, they want decrease of IOP, normal IOP, even in the second day. So it's not possible by RD. So I try mostly Ahmed valve, but in some cases, of course, we have to do RD. And result is in the long-term IOP control is not bad. So lastly, I'll say that when everything fails, then you have cyclodestructive procedure, especially if the patient is having non-seeing eyes. You can think of cyclocryopexy, diode cyclophotocoagulation. And if it is seeing eyes, nowadays the micropulse laser photocoagulation, the Z6 probe, has very good result even in the primary, as a primary surgery. So we can think of using the micropulse, think of using the endoscopic cyclophotocoagulation in the management of residual glaucoma. So in conclusion, I would say actually every trabeculectomy, not only trabeculectomy, every glaucoma surgery has limited time that will be successful, and ultimately it will fail regarding the control of intraocular pressure. What we have to do, we have to do meticulous surgery. We do starting from preoperative operation, do a best surgery so that have best result. And if occurs, identify in the early stage of the residual glaucoma so that you can address the problem right time in the right way. This way we can definitely correct our residual glaucoma for the betterment of the patient. Thank you so much.